Today we have the pleasure of having Dr. Sultan Chaudhry presenting with a fantastic title, Magnesium, the Forgotten Cation. We do forget about magnesium, so it is a neglected electrolyte. So thank you for highlighting that today. So a little bit about Sultan. So he studied undergraduate medicine and postgraduate medicine at McMaster, and he works in the cardiovascular division at Hamilton Health Sciences and in the ICU at Niagara Health. His clinical interests include heart failure and cardiorenal syndrome, and his personal interests include martial arts and cooking. So thank you for coming today. And as a side note, Sultan is also a master of medical trivia. He has dominated at ACP Doctor's Dilemma for many years as a resident, and he should put that on his resume because it is truly impressive. His medical knowledge is like unparalleled. And if you want in the Q&A, ask him anything and he will have an answer, not just magnesium. So thank you for coming today, and I'll hand it over to you.
Thank you, Samir. That was a very glorious introduction. I'm not sure I'd be able to keep up with that, but do my best. I would like to start with the land acknowledgement that we're privileged to provide care on land that Indigenous peoples have called home for thousands of years. I don't have any disclosures. Objectives. We'll talk about some magnesium homeostasis very quickly. Renal handling of magnesium. A few years ago, if there's anybody from the nephrology division that's joined in, I did a talk purely on the renal handling of magnesium, where we went through the various channels, how we came to discover those channels, and some of the systemic disorders that arise from channelopathies in the nephrons and how they manifest clinically that have enhanced our understanding of the renal handling of magnesium. But I only would like to spend maybe perhaps at best 5 minutes on that area, and then more applicable to general medicine, broadly, hypomagnesemia, its manifestations, its relationship with calcium in particular, as well as potassium and some acquired causes. And I added a decent amount of section in this talk on the role of IV magnesium in various emergencies that we see in internal medicine as well as ICU that we can chat about. So very briefly, it's obviously essential to all living cells. When you look at some of the cellular reactions, magnesium is a cofactor and an enzyme in many of them. It's a central structure of the chlorophyll molecule that gives plants its green color, hence the leafy greens being one of the optimal and best sources of magnesium in our diet. It's the second most divalent ion, very close to calcium in our body. It's the second most ion in the cell next to potassium, just surely highlighting its importance as a molecule in the cell. Aside from the greens, nuts and beans are high sources. This was in a summary paper in New England Journal of Medicine published very recently, where it goes through various steps and processes that magnesium plays a large role in. Calcium antagonism we'll talk very heavily about when we get into magnesium as a potential treatment option for 3 separate emergencies that we use it for. There's a lot of, one of the interesting things that I get asked about in a non-medical circle nowadays is whether they should be taking magnesium supplementation for sleep regulation. And a lot of people swear by it. I didn't find anything specific about it, but it's obviously involved in circadian rhythm maintenance. So there's definitely something there. I just don't think we've discovered it yet. Enzyme activation that I talked about, DNA replication, all the things that I would briefly touch on. And most importantly, its role as an enzyme from conversion of ADP, phosphate to triphosphate, which is the most active source of energy for the cell. So very simply, intestines take it up after we consume it from our food. There's a number of pathways involved there that I'll get into the detail of. Bone and soft tissue are the main reservoirs, stores. Its magnesium is the central component of hydroxylapatite, which is a large bony reservoir. Kidneys, they filter it and then reabsorb majority of what's filtered. And it gets excreted in the urine. So this diagram shows from food ingestion, involvement of gut, 60% of it being stored in the bone at all times, and then the remainder of it that is maintained in a homeostatic balance. And over there, the kidneys filtering it and urine excreting some small quantity of it. In the intestine, small bowel and large bowel are slightly different in terms of the way they absorb it once we ingest it in our food. Small bowel is predominantly, so 90% of it overall is involved through the paracellular transport. I'll get into the role of claudins, which are the channels that are involved in maintaining the paracellular control. 16 and 19 being the predominant ones, and claudin 14, which is actually an inhibitor of both of those claudins. So claudin 16 and 19 form this heteromer that claudin 14 can essentially block, and it's particularly important when it comes to drug-induced mechanisms that cause hypomagnesemia, because some drugs inhibit that formation, and some drugs upregulate claudin 14, which is an inhibitor of the uptake. And then there's the active transport, which is mediated by these TRPM 6 and 7 channels. And it's very important, as well as some drugs that inhibit those channels that we'll discover later on. So as you can see in this bottom diagram, you've got the paracellular transport that's mediated by the claudins, and then the active transport that's mediated by the TRPM 6 and 7 channels. Are people able to see my mouse moving or no?
Yeah, I can see the mouse. Yeah, I can see it. Yeah.
Okay. Now we get into renal handling. So I skipped a large part of the bone because it essentially is not as interesting of a process, and I would like to focus more on the hypomagnesemia aspect of it. So in various segments of the nephron, a lot of the action, as you can tell, takes place at the thick ascending limb of Lupo Henle. About 50 to 60% of it gets absorbed, reabsorbed there, and then a lot of it gets modulated in the distal convoluted tubule. So I won't focus too much here because it looks very confusing, but it's actually a lot simpler than that. So this is claudin 16 and 19 that I already mentioned. This is a Lupo Henle tubular cell. To those being oriented on the left over here, the yellow is the prourine, and over here is the basolateral side where it gets absorbed in the interstitium. So you've got claudin 16 and 19 forming a heteromer, and then you've got 14 in the middle that acts as an inhibitor. And important to note that this segment of the nephron, magnesium and calcium move together, which is relevant when we talk about clinical manifestations and urinary composition of issues related to magnesium and whether calcium is helpful or not. You've got the sodium-potassium dichloride channel, the infamous channel that Lasix blocks to induce diuresis. And you've got the renal outer medullary potassium channel. Important part I'd like to highlight is the inhibitor on the inside is magnesium. So abundant presence of magnesium intracellularly leads to inhibition of the ROMK channel. So if you don't have enough magnesium, you would not have the inhibition, and therefore you would continue to induce caluresis. Over on the basolateral side, you've got the sodium-potassium ATPase that we're all aware of, and then you've got the chloride channel that's involved in certain types of Bartter syndrome. You've also got the calcium sensing receptor that abundant calcium binds to, and then subsequently leads to underexpression of the sodium-potassium dichloride channel, leading to a ton of diuresis, hence hypercalcemia being mimicking a diuretic there. This will all become applicable when I get into a little bit more detail related to magnesium. So important parts are the calcium sensing receptor. You've got the channel over here, the ROMK, the claudins over here, mediating paracellular transport of magnesium. So very briefly, two separate genetic disorders. First one related to mutations in claudin 16 and 19 when they have animal models that mimic these mutations. A complete mutation leads to death in utero because it's just magnesium is that essential to the growth. And when you've got mutations in it that render it somewhat ineffective, you've got profound amounts of hypomagnesemia. Bartter syndrome, as I previously mentioned, which is like being on a diuretic, particularly Lasix. There's various forms of them. In one way, shape, or form, you end up with reduced function of the sodium-potassium dichloride channel. And depending on the type of it, you almost inevitably end up with hypomagnesemia, showing that, and this part of it, it's not necessarily the transport, it's more so the charge-mediated mechanism that leads to magnesium and calcium absorption through the paracellular route. So over here, a little bit more complicated because it's more regulated, is a distal convoluted tubular cell. More relevant here is the sodium-potassium channel that the thiazide diuretics block. You've got a rarer channel which is just called the Cur 1.1 potassium channel. You've got over here, more important, the same channels that are present in the intestinal cells present here, the TRPM 6 and 7. And you've got the EGFR, which is the epidermal growth factor receptor. It's also become more relevant when we talk about drugs and get into their details. And you've got the same Barton, the chloride channels, and the sodium-potassium ATPase on here. So in terms of genetic syndromes, Gittleman syndrome that is that is known to be essentially the thiazide diuretic that mimics the sodium chloride channel blockade. You get very mild hypomagnesemia in patients who are on thiazide diuretics, and Gittleman syndrome patients get similar manifestations. Hypomagnesemia with secondary hypocalcemia, the genetic disorder that is related to mutations in your TRPM 6 and 7 channels. Then you've got isolated renal hypomagnesemia over here due to mutations in EGFR channel, where people get purely just renal magnesium wasting. And then you've got autosomal dominant hypomagnesemia with hypocalciuria, which is related to a deficiency over here in the gamma subunit of the sodium-potassium ATPase on the basolateral side, where these people also result with mild to moderate hypomagnesemia. And East syndrome, which is one of the neurological syndromes that's related to the Cur channel on the basolateral side, also has findings in keeping with mild to moderate hypomagnesemia. So all to say, the last few slides to show how we came to learn what we know about magnesium handling in the thick ascending limb loop of Henle, as well as distal convoluted tubule. If I can give away something, is simply there's paracellular transport, and then there is the channel related transport. And at various levels of the nephron, you can have problems that lead to both magnesium and calcium wasting, or isolated magnesium wasting if it's one of the pathways that's affected in the distal convoluted tubule of the nephron. Hypomagnesemia, its associations with calcium and potassium that I've already started to touch base on. Its presentation from mild, moderate to severity. mild, moderate to severe, and some of the acquired causes. So those are the two big derangements that you see often in patients with hypokalemia. In hypomagnesemia, you get profound hypocalcemia and hypokalemia, and the mechanism is well known. So one of the things that's needed for release of PTH from your parathyroid cells is magnesium. And when you've got magnesium deficiency, those cells are unable to secrete the parathyroid hormone, and therefore you're not able to see the end effects that parathyroid hormone would exert on various organs. Secondly, 1-alpha hydroxylase that a lot of people might be aware of in the context of hypercalcemia. One of the ways granulomatous diseases and lymphoproliferative disorders cause hypercalcemia is through increased function of 1-alpha hydroxylase, which has an important role in conversion of 25-hydroxyl vitamin D to 1,25 dihydroxyl vitamin D. So when you get deficiency of 1-alpha hydroxylase, you have ineffective vitamin D, and therefore you're unable to absorb calcium at the level of the kidneys as well as the gut. And this hypocalcemia that's present, it usually obviously does not reverse unless you replace the magnesium. Hypokalemia, is more the renal outer medullary potassium channel that I talked about that's present throughout the nephron, but depending on the segment of the nephron, its density rises or reduces. And magnesium acts as a suppressor of the activity of the ROMK channel. And if you don't have enough magnesium, you tend to have a profound amounts of caluretic effect, where your nephrons tend to dump a ton of potassium in your urine. This is a graph that's comparing a presence of electrolyte derangements in the presence and absence of hypomagnesemia. This is taken from a cohort of patients with heavy alcohol use. So blue, green, and red. And you can see if hypomagnesemia is present, you tend to have a significantly higher amount of other electrolyte derangements, starting from calcium, sodium, as well as potassium. I think the sodium is more so a nutritional thing, as in, as we call beer potomania or reduced tea and toast diet. So they just don't have enough osmoles. So I don't think the homeostasis is directly impacted, but the other two is well known in terms of the mechanisms that I've just described. Signs and symptoms, they start to develop when you even hit a mild hypomagnesemia. You can have early symptoms and obviously more profound delayed symptoms. They're very non-specific unless it becomes more profound, and some of those are overlapping with symptoms of hypokalemia as well as hypocalcemia. The spasms, the tetany, and the seizures, cardiac arrhythmias, things that would probably get into the detail of in terms of treatment as well, prolonged QT as well as Torsades-Dupont. So over here, again, reiterating that the conundrum and the spectrum of symptoms is probably somewhat tied directly to how hypocalcemic and hypokalemic patients are as well. And obviously severe cases causing VT and TDP. Acquired causes, I think we can start off at the gut level and then go on to the kidneys after. So because absorption is taking place at the level of the gut, if you've got interference with the absorption, you've got stomach acidity, pH maintenance, and the shift of that going from the stomach to the small intestine and the large intestine. And then you've got the element of the way it's absorbed. So you've got the two mechanisms that I earlier talked about, a small bowel as well as a large bowel. So you've got between cell transport, and then you've got the active transport through the channels. So obviously, you need time for the ion to be present in the gut. So if you've got any sort of malabsorption syndrome or anything that leads to hypersecretion and diarrhea, you just don't have enough time to absorb the magnesium, and therefore you would end up depleting your stores, eventually manifesting into signs and symptoms of hypomagnesemia. PPI and alcohol use are more interesting ones as well. Alcohol has an overlap with reduced oral intake as well, because majority of people who have trouble with high alcohol consumption are obviously not as mindful of their diet. PPI is a very interesting one and probably the most well-studied as well. And I'll get into the details of that. And I think acute pancreatitis is a mixed bag of things, including reduced oral intake, some getting diarrhea if it's chronic pancreatitis as well. So here's a representation you can see on the x-axis and the y-axis showing the difference as you have presence of PPI, how magnesium is present in terms of its free form that's readily available for uptake. And then you've got the insoluble form and how the luminal pH, due to the presence of PPIs, does not render the magnesium ion available for uptake and transport. So that's one thing. With a change in pH, specifically pH rising due to proton pump inhibition, you've got, number one, reduced presence of free-flowing magnesium that's available for uptake. Secondly, you've got the presence of the TRPM 6 and 7 channels that I was talking about earlier. And PPIs have been thought to directly not only inhibit those channels, but also actually play a role in inhibition of the claudins that I was referring to earlier that are responsible for paracellular transport. Over here, it's the effect on the TRPM 6 and 7 that I was talking about. But because the cell is more so present in the colonic segments of the gut rather than the small bowel, you see the effects more and somewhat related to the gut microbiome as well, because PPIs have been recently thought to significantly impact the gut microbiome and how that renders the TRPM 6 and 7 availability. At the level of the Lupo-Henle, this is the same cell again. Over here, you've got loop diuretics that block the sodium-potassium ATPase. Sodium-potassium dichloride channel, not ATPase. You've got calcium urine inhibitors, which are more common and prevalently used in transplant populations. Not only do they directly inhibit claudin 16 and 19, they actually upregulate claudin 14 as well. Over here, you've got the calcium sensing receptor. If you've got hypercalcemia, obviously a lot more calcium gets placed in the prourine because it gets filtered through the glomerulus. And over here, a ton of it gets taken up because there's a lot more of it. And on the basolateral side, you have excess calcium binding the calcium sensing receptor. There is also another arrow where direct activation of calcium sensing receptor over here inhibits the expression of sodium potassium dichloride channel, essentially mimicking being on a loop diuretic, hence hypercalcemia being termed as pseudo-Bartter syndrome, because Bartter syndrome would directly lead to inactivation. And there is a form of Bartter syndrome that's linked to mutations in the calcium sensing receptor. Cisplatin A does essentially the exact same thing, and aminoglycosides, which are antibiotics. I think both are known to be tubulotoxic, but one of the main mechanisms by which they drive magnesium loss is actually direct binding with this calcium sensing receptor. At the distal convoluted tubule, a little bit more regulation. You've got role of thiazide diuretics that I was talking about earlier in terms of Gittleman syndrome. You've got calcium urine inhibitors that play a role in inhibition of TRPM 6 and 7 as well. And ethanol is well known to be just the way it was in the gut. inhibitory towards TRPM 6 and 7, hence reducing uptake of magnesium and causing direct magnesium loss. Sometimes at Jurvinsky, you do see the isolated hypomagnesemia, which is from the cetuximab and erlotinib, which are direct inhibitors of EGFR. That's just their pure mechanism of function, which is essentially isolated hypomagnesemia genetic disorder that I was talking about earlier. So in summary, you've got loop diuretics, cisplatin A, aminoglycosides affecting at the thickest ending limb loop of Henle, and then you've got calcineurin inhibitors. Pentamidine is another one that essentially is very, very similar to calcineurin inhibitors in terms of its impact on TRPM 6 and 7. Pentamidine is one of the HIV drugs, or it used to be at least. I'm not sure if that's evolved. I think it still is. And then ETN and post-obstructive diuresis in general due to the loss of appropriate tubular cell function and channel function. And over here at the distal convoluted tubule, you've got the thiazide diuretics, calcineurin inhibitors, and the biologics that we talked about, the EGFR inhibitors, cetuximab and erlotinib. I think approach to hypomagnesemia is fairly still quite clinical. I think history should probably give away a ton of it. I was just telling Dr. Raza last week on call, we had a patient with severe hypomagnesemia. They came in with muscle cramps and a syncopal episode that probably was a seizure. Their magnesium was undetectable. Their calcium, their ionized calcium was just around 1.2, and or maybe even less than that. And their potassium was around 2.7. And they'd been started on a PPI in Poland a few months ago. And I think a lot of that was just present in the history. But taking a history from scratch, asking for GI losses overall, dietary habits that might point to reduction in intake, alcohol consumption, a complete list of medications to see if it's any of the culprits that we that is well known to us. The fractional excretion of magnesium, it's difficult to perform, and it has also got its own criticisms because it's not under any hormonal control. Our gut reaction when we see somebody with low magnesium is to just give them IV magnesium. The homeostatic process takes a fairly long time, and if you give somebody a ton of IV magnesium, they don't particularly have major regulations like calcium, sodium, and potassium with the hormonal system. So if you notice throughout the talk, I have not talked about a single hormone except for a weak role of PTH in terms of magnesium uptake and regulation, which makes it a little bit tricky because you don't have the appropriate checks and balances in place when it comes to major losses or delivery of large amounts of magnesium that you would have some checkpoints that could control and regulate it in the body. However, you can still perform it, and as long as no major amounts of magnesium has been given, it should be able to give you an answer that you're looking for. Obviously, just general principle of physiology, if you've got low urinary magnesium, you've just essentially got for intake, or you've got some sort of a gut absorption issue. And if you've got high amounts of urinary magnesium, you know you're losing it in your urine. And if it's associated with the high urinary calcium, as I was referring to earlier, it probably points towards a thick ascending limb Henle issue. And if you've got low urea, this is a bit more important to pediatric populations because they might see one of these genetic disorders more so than adults would be. And then if you've got essentially normal urinary calcium, it might be somewhat related to the epithelial growth factor related issues. I want to touch base briefly on magnesium as a treatment modality. So torsades was first described in 1966 by a French physician. I'll definitely botch the name, but I believe it was Dessertin. And he described it as a French term for twisting peaks. and eventually obviously found to have a number of reasons why you get it. You see an R-on-T phenomenon forming right here. That leads to this polymorphic VT appearance. And related to specifically TDP, it's a prolonged QT because you can get polymorphic VT from other mechanisms as well. But specifically TDP, it's from a prolonged QT. First report of use of magnesium, there is a paper in circulation from the early 80s. They reported 3 case studies in patients who had been on quinidine, as well as some of the other class 1 antiarrhythmics, if I remember correctly. And those authors actually got the idea because at the time, there was some thought that because magnesium is so prevalent near the myocytes that it's got some role in maintenance of myocardial stability. So it was being actually used in some places in acute MI as well as ditch toxicity. So when there was a rise in cases and identification of TDP, the third case in that case series or study, if you want to call it, it was just 3 cases. And the third one was actually from an antidepressant overdose that somebody had presented with a prolonged QT. It was a TCA, it was a tricyclic overdose. And they were able to use magnesium and stabilize the patients and get them out of this polymorphic VT, TDP. And if you look at the action potential, phase 2 is where you've got opening of the calcium channels, and that's where they believe magnesium was responsible in terms of causing stability, leading to aborting of these arrhythmias. So I'm sure many people see TDP in their practice or have studied it, and this is one of the mechanisms where it's thought to have an effect on myocardial stability. And obviously, it's one of the first line agents, so its use is very important. Asthma exacerbation is another interesting area. When I was actually doing some research for this talk, it's actually very questioned lately. There's a lot of literature pointing against it. However, the global international asthma guidelines, they call them GINA, they still recommend quite strongly that magnesium should be given only in severe exacerbations. Mortality has obviously never been studied, but hospitalizations and discharge from emerge has been studied, and magnesium impacts both of them. So they still recommend that magnesium be given in severe exacerbations. And because it's a calcium antagonist, if you want to almost call it that, because of the divalence and its ability to bind a divalent ion receptor, you've got a ton of calcium channels in your smooth muscle, and it's thought to perhaps alleviate some of that stress and constriction from the smooth muscle cells. There is some evidence that it's got some short-term immune modulation role and its ability to keep mast cells in check and cytokine production. A lot of that is debated. It's very new. Plus, there's not a whole lot of interest in it because it's not particularly Nobel Prize worthy or grant worthy. So the research is still lagging behind, but it makes sense somewhat physiologically that you've got a ton of calcium channel in your smooth muscle cells in the airway, and their blockade would lead to relaxation of the smooth muscle cell. But we obviously know that asthma exacerbation is much more than just a smooth muscle cell issue. Third, preeclampsia and eclampsia. Those are some of the clinical manifestations or biochemical manifestations of eclampsia from preeclampsia. And use of magnesium sulfate over there is not controversial. It's given quite aggressively, probably one of the areas where aggressive IV magnesium supplementation is recommended. Over the in the chart, you can see the cellular target of magnesium in the first column, its mode of action in the second column, and potential and possible mechanisms by which magnesium might be able to assist in this situation. And eventually, most importantly, what happens at the level of the endothelium at the capillary level. So you've got the uterine, mesenteric, aorta, as well as cerebral arteries. You can see that it induces a lot of vasodilation. That's the end result, and decreased platelet aggregation, which is one of the big factors in DIC and just overall blood pressure and vascular health maintenance in that emergent settings. But what's interesting to note is in the cerebral vessels, it has the least impact, which I find very interesting, which is actually the only reason why I looked into this. Because when you look at it, one of the things that happens in eclampsia is you can get eclamptic seizures. So when you look at the cerebral endothelium, it actually does not have nearly as much vasodilatory effect, because you want to actually have the opposite effect. So it actually reduces the disruption in the blood-brain barrier. A lot of this data obviously comes from animal models. It minimizes the transport across the blood-brain barrier as a protective mechanism, and it reduces that tight junction permeability. So are the hypothesized mechanism. One of the things linked is cerebral edema, and its impact on the astrocytes leads to essentially reduced expression of aquaporins that directly cause more swelling and increased water uptake, if you guys remember aquaporins. Over here at the level of the nephrons, NMDA receptors that have been shown to have a link in epilepsy, and some of the drugs, anti-epileptics, they work through the NMDA pathway. And you can see that when you study this in animal models, it significantly increases the seizure threshold at its presence of magnesium. And that's thought to be mediated by the NMDA receptor antagonism. So in Prasad's severe asthma exacerbations and preeclampsia, a lot of calcium channel blockade due to competitive inhibition, suppressing the early after depolarizations that cause the R-on-T phenomena is inhibited in the presence of magnesium. You've got bronchial smooth muscle cells and suppression of mucosal immune response in the presence of magnesium potentially. And you've got endothelial and prostaglandin and nitric oxide release that eventually leads to relaxation and vasodilation, but not getting the same effect at the level of cerebral vessels and endothelium, and over on the NMDA receptor antagonism side, increasing the seizure threshold, which I find quite interesting. So I think in summary, I can leave people with, it's a very abundant, it's a very essential ion. It's not under any hormonal control, which I find quite interesting, unlike sodium that's got ADH, aldosterone, renin. Potassium has got aldosterone and cortisol, and calcium has got PTH, vitamin D. Magnesium has got no hormonal control. Steady levels, you consume it in your diet, you uptake it from the gut, and then you filter it through the kidneys and reabsorb some of it. And we talked about some of the mechanisms by which you do. Hypokalemia and hypocalcemia are two directly tied electrolyte abnormalities to hypomagnesemia, and we talked about the mechanisms by which that happens, and magnesium deficiency needs to be corrected for those metabolic derangements to occur. I didn't talk about metabolic alkalosis here because I don't think that's a direct correlation with hypomagnesemia. I think that's more a hypokalemia-mediated mechanism. We talked about drugs and their mechanisms, largely reduction of gut uptake via various mechanisms, increase in renal losses via various mechanisms that cause hypomagnesemia, and some of the ways IV magnesium supplementation can be life-saving in some emergencies, the three that we talked about, and the mechanisms that are hypothesized behind why magnesium is so effective in those situations, except for the asthma exacerbation, because that literature is quite debated. And that's all. I was told to leave 15 to 20 minutes for questions. Happy to take any.
Perfect. Thank you very much, Dr. Cuddy. That was a fantastic presentation. I learned a lot. I didn't really understand all the mechanisms of magnesium and its roles throughout the body. So I'll open up to questions. I have a few, but I see we have Dr. Connolly with the first question. So I will unmute you. All right. I think you should be okay, Dr. Connolly, to go. Yeah.
Oh, hi, Sultan. Thanks for reaffirming my lack of knowledge about magnesium. What would be your oral replacement of choice? We often have patients in a heart function clinic and cardiology clinic with low magnesium due to diuretics. We can't really give IV magnesium in that setting. What's your approach to replacing orally if that's needed?
So this has been looked at. Unfortunately, oral magnesium supplementations cause diarrhea, and they don't necessarily understand. Last I remember looking at this literature, they didn't have a great grasp on why a lot of oral supplementations cause diarrhea. Magnesium Rougier is one that has more association with diarrhea than one of the other formulations. I don't have a lot of long-term follow-up with patients, but I always try to encourage people to increase their foods that are high in magnesium as opposed to directly replacing it. Although it may not be as effective, you can bypass some of the side effects. And I do think a magnesium supplementation that wouldn't cause diarrhea would actually be quite popular if somebody ever invested some time and energy into it. But to answer your question directly, I always encourage patients to, obviously, if they're on something that we can change, which heart function patients, obviously, we can't. And related to that, I'll get into something else shortly, but Magnesium Rougier is the standard supplementation that's present. And I tend to try to tell people that they can split it up. They don't have to take it in one single pill form or drink form. But usually it causes diarrhea, and that's one of the main reasons why people don't take it, because diarrhea in turns then further reduces your magnesium levels. Interesting you mentioned that SGLT2 inhibitors actually have been shown to decrease magnesium loss in the kidney, not gut. So perhaps that would be helpful to some of the heart function patients that you guys have, Katie.
That's interesting. Neat. Yeah. Neat. Thank you.
So I have a couple questions to ask. So the first one was, when you were talking about measuring urinary magnesium, you said if we're giving IV replacement, it could impact it. Like, we're often giving 2 to 5 grams IV when we're replacing. Would that level of replacement impact your urinary measurements?
Yes, it would. And it does. And that's been studied, because when you give somebody directly IV magnesium, due to the lack of hormonal control, it just gets directly filtered. All of it gets filtered. And then if you've got an area at the level of the kidney that's driving the problem is going to persist. So you're going to end up dumping that magnesium right out. So it definitely impacts it. So I haven't done any outpatient nephrology in a couple of years, but we did used to see the odd hypokalemic referral. And those patients actually, you can do 24-hour urine collections and it's helpful. When you're doing inpatient medicine, you almost inevitably, if you discover hypomagnesemia, unless you can get a 24-hour urine collection right away, but a lot of the times if the patient has come into contact with the emergency, our knee-jerk reaction is just to replace the magnesium, give them 2 grams, 4 grams, 5 grams. So you might have to wait for maybe a day or two before you can do a urine collection that won't be as impacted by that. To answer your question, yes, just giving that much in a single time and then trying to do a 24-hour collection, it is impacted. And that has actually been studied as well.
Okay, that's very helpful to hear. So thank you. Dr. Holbrook, you had a question?
I did. Thanks, Sultan. Just a couple of comments and a question. We have a research program on QT prolonging drugs. So, torsade and magnesium comes up all the time. And related to hypomagnesemia, in medicine, the perfect storm is a PPI, very high levels of alcohol use, and diabetes. You can almost expect some hypomagnesemia there. But regarding the torsade, it's interesting after, looking in the literature for quite some time, I don't actually see any good evidence that magnesium itself helps torsade unless the magnesium levels are quite low. I think it's a crash, so we're doing a whole bunch of things. But I do recall Jason Roberts being somewhat nervous about what we were doing around trying not to blame the medications, that there's a whole bunch of factors that lead to torsade. Magnesium may be one of them, and a lot of the medications actually could be innocent bystanders because the levels of evidence are so poor. And by the way, torsade is rare. In going through all of Dovetail, we find no mention in the problem list and diagnosis of torsade. We know that it occurs, but we actually have to do some AI, natural language processing, to find it. So my question is, do you feel like if people's magnesium levels are normal, have you found good evidence that magnesium itself helps torsade?
So it's interesting that you mentioned that. And I didn't know that until a few days ago when I was doing research for this talk, actually. And I do agree. And I didn't want to get into the details of it. But generally, from what I found in the literature, there was a lot of criticism of this idea that magnesium is actually, whether it should or shouldn't be used. I think a lot of people are scared to comment on that just yet. But the presence of normal magnesium levels and whether that in those patients, torsade actually they benefit or not. So I do agree that I think that area is questionable now. And I think people are scared to comment on it because it's just, I think the American Heart Association, if I'm not mistaken, magnesium is class 1C indication if you see a polymorphic PT, regardless of serum magnesium levels. Correct me if I'm wrong there, though.
Yeah, I know I think the Canadian guidelines might be even a bit more recent, and they do recommend it and don't actually give it a classification. So I agree. Like it's on that. What worries me always is these medications where we don't really have good evidence. They turn out to be not that important, but it delays, going after, potentially more effective medication. So it would just be good to see better evidence out there.
Dr. Pradana, you had a question? Maybe.
Sorry, I just didn't. Thanks, Sultan. Nice to see you again. Nice overview. Yeah, we often see hypomagnesemia with osmotic diuresis and diabetes, poorly controlled diabetes. When you control their diabetes and their magnesium normalizes, their potassium normalizes. I just remember reading about independent of osmotic diuresis, that insulin resistance in diabetes can have an impact on magnesium metabolism. Any thoughts on that or recent evidence on that?
Yes. I was suspecting somebody would ask that question. I don't know if I put it in one of my supplementary slides or not. So that is quite a lot of newer literature. And one of the things that literature mentioned was that insulin resistance at the level of the tubular cells has a role in inhibition of the same channels, the TRPM6 and 7. And that was one of the proposed mechanisms because healthy insulin balance is known or needed for the expression of those channels and hence magnesium uptake. But it's interesting that you mentioned that. And that is the proposed mechanism, that insulin resistance eventually leads to decreased uptake of magnesium from the distal convoluted tubule. So that's the mechanism. And one of the things is when you control their diabetes better, they tend to have improvement of that hypomagnesemia. And again, it's quite weak and right now talking about associations. So does that answer your question, Dr. Pertain?
No, that's great. I think everything is related to diabetes, isn't it?
Yes.
Okay, so I have another question. I'm going to capitalize on your cardiology experience as well. So I took part in a critical incident call a while back, and someone developed an arrhythmia, and someone said, "Oh, the magnesium was a little low and it wasn't replaced," and the magnesium was like 0.6. And it got me thinking: is there strong evidence to support maintaining magnesium above 1? Because I see this written in everyone's notes, and anyone who has any arrhythmia maintain mag above 1. So 1, is there good evidence for that? And 2, how aggressive should we be being in trying to replace people's magnesium in the context of a cardiac history?
I think a lot of the evidence is quite old. I think a lot of the evidence is more observational. So that's the first point. I don't think there's any strong evidence. And I think a lot of the evidence is usually physiologic because people see its correlation with potassium and calcium. It's interesting that you mentioned that. I was talking to a cardiologist because of a monomorphic VT last week, and he was so keen. I said the patient's magnesium was 0.87 because they were so confident. They were like, "This is you need to do this and you need to do that." And as he said, "Okay, give him tons of magnesium." And I said, "Well, his magnesium is 0.87," and he's like, "No, give him more. Give him 2 grams. Give him 3 grams still." And I think it's a lot of it's fear around what would happen if it was, number one, lower. It's a lot of fear around, I think, medical legal side of things. And I think that stems from people see its role and its discussion around TDP in general. So I don't think there is a direct correlation at mild hypomagnesemia with any arrhythmias. I think when people see its relationship with potassium, people say, "Oh, just..." And additionally, it's an easy fix. Give them 2 grams of magnesium or 3 grams and get it up above 1. I think usually people that have hypomagnesemia, it's the good thing is it's got a clear cause if you take a detailed history. So it's probably better to fix that cause rather than continue to dump magnesium intravenously. And the third thing that I wanted to mention was, now I'm blanking on it, but there was something else that I was going to say. Does that answer your question?
No, definitely. Yeah, my observation was the same, that there's this very strong feeling that we need to fix the magnesium, and again, that case prompted me to be like, well, why do we feel so strongly? What is this based on? Should we be going back to the physician and saying, why weren't you more aggressive? But, based on what I'm hearing is this is a thing that we should do, but it's not based on a whole lot for mild hypomagnesemia. But again, if it's more severe, we should be being more aggressive. So that's kind of what I was thinking, but want to make sure I wasn't missing anything else.
No, that's exactly it. And that's what and this is not my opinion. This is on the basis of what I read and see in the literature. And I think that I just got the third point that I wanted to mention is that I think by the time we see hypomagnesemia present in the extracellular segments, but because such a large amount of magnesium is stored and put away intracellularly and in the bone compartment, that I think the depletion has to occur over several months. Because I remember somebody was commenting on one of my notes where a patient had started a PI, I think 9-10 months ago. And they said, well, why are you seeing it now? Why didn't you see it? Why didn't you see the hypomagnesemia in the first week? They're presenting now. I said, it takes a lot of time for you to deplete your stores because you've got so much of it put away. So by the time you're seeing serum hypomagnesemia, you're probably overall total body deficient. So I don't know if that's got something to do with the cardiac arrhythmias, but in general, I do think if your body is able to replenish it and and it's available for use in myocardial stability, you really should not, that fear should not exist around just mild hypomagnesemia.
Okay, well, that's very interesting. So it's almost like a DK where you have dramatic total loss. I wasn't applying that frame to hypomagnesemia, so good to know. Dr. Ferdani?
Yeah, that's a common teaching that I tell the residents, that even if the serum magnesium is normal, it doesn't reflect total body magnesium, right? I just remember when I was training at St. Mike's with Mitch Halpern and Kamel, and at that time he said, if you're not really sure and you don't want to treat because of the risk and the benefit, do a red blood cell magnesium. Is that something we can do still? Is that of value? Was that evidence-based? Maybe you can comment on that, because I haven't ordered it for ages.
To be honest with you, I don't know much about it. Kamel never told me that. But I'm sure it exists, Dr. Bertani, but I would have to look into it. I'm a little bit surprised to hear that. Maybe I'll text Clive tonight.
All right. Any last questions? We have about 2 minutes.
I'll make a comment related to the comment that Dr. Holbrook had said. I just got a text from Dr. Tallman, who made a very reasonable point that I think if you're seeing somebody with torsades, I think a lot of people are going to jump to give magnesium so quickly and relate it to the renal handling aspect and the fact that you'll probably not find their serum levels to be as low as they were because they've already received the mag. I mean, I'm not saying all of it's going to stay in their serum. They'll probably end up losing some in their kidneys. But I think that's a very reasonable point that by the time you get to see that patient or get their magnesium level, it's not going to be the accurate magnesium level either. So there is that, I guess, confounder present as it pertains to magnesium and levels and torsades. But generally, the literature, I was very surprised to see the lack of evidence and support for especially mild to moderate hypomagnesemia in torsades.
Oh, very interesting. Okay, so we've come to almost 1 o'clock. So I think we will conclude. So thank you very much, Dr. Chaudhry. That was a fantastic round, a great discussion and questions from anyone. Really appreciate you taking the time to come teach us today, and look forward to seeing everybody next Thursday. So have a good afternoon.
Thanks, everybody.